किया हुआ है सर सबको, जिसको जो क्वेश्चन करना होगा सर वो हमारे चैट में कर लेंगे सर।
हाँ वो आखिर में कर लेंगे, ठीक है। तो मैं स्टार्ट कर दूं?
जी 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 सर स्टार्ट।
ओके, बिस्मिल्लाहिर्रहमानिर्रहीम। Today we will discuss community acquired pneumonia, clinical diagnosis, severity assessment and management. I am Dr. Faisal Fayaz Zubairi, working as Associate Professor of Pulmonology in Dow University of Health Sciences. So before going to community acquired pneumonia, we should have some background of what they are respiratory infections and how do we classify them. So generally, respiratory infections are classified as upper respiratory tract infections and the lower respiratory tract infections. Okay. And among the upper respiratory tract infections are the rhinosinusitis, pharyngitis, otitis media, epiglottitis, laryngitis. And among the lower respiratory tract infections generally are pneumonia, lung abscesses, like this. All right. So how to approach the patient who may have respiratory infection? There are certain questions one need to ask when we think that that patient might be suffering from respiratory infection or pulmonary infection. First of all, the first question is it really an infection? Sometimes patient may have a neoplastic process or cancerous process or inflammatory process, not infected process. So first of all, when we have suspicion the person is having pulmonary infection, the question is it really infection? Then what type of infection is it? If it is a pulmonary infection, then what is the type? Is it viral? Is it bacterial? Fungal? Is it parasitic? Like this. How severe is the illness? Severity assessment. What is the likely pathogen? And lastly, then how do I identify that pathogen which is causing the disease? There are certain terms when we call the person is having pneumonia. CAP, which stands for community acquired pneumonia. And this is the topic of our today's talk. Hospital acquired pneumonia, HAP. Healthcare associated pneumonia, HCAP. This term is almost abundant nowadays. We don't use it anymore. But for the sake of completeness, we are mentioning it. VAP is ventilator associated pneumonia. And then we have pneumonia in an immunocompromised individual. This immunocompromised status can be HIV associated and can be non-HIV associated. Okay. Now these are the definitions. So if you talk about HAP, so HAP, as the name suggests, is the hospital acquired pneumonia, is a pneumonia occurring 48 hours or more after hospital admission, and that was not present at the time of admission. For example, a person was admitted with acute pancreatitis, and on admission, his or her X-ray of the chest was normal, but after 48 hours, he was becoming short of breath and developed a pneumonia. So this will be labeled as hospital-acquired pneumonia because it was not present at the time of admission, and it developed 48 hours after the hospital admission. VAP, ventilator-associated pneumonia, is pneumonia occurring 48 hours or more after endotracheal intubation. This is further divided into early onset and the late onset. First 4 days, and from the 5th day onwards is the late onset. The healthcare associated pneumonia, the term which we usually don't use anymore, but that used to include patients who have been recently hospitalized within 90 days of infection, resided in a nursing home or long-term care facility, or received parenteral antimicrobial therapy, chemotherapy, or wound care within 30 days of pneumonia. So let's come back to the major thing, which is the CAP, community-acquired pneumonia. This is defined as acute lung parenchymal infection with clinical and chest radiograms consistent with infection that was not pre-existing or of any other known cause in a patient not hospitalized for 14 days before the onset of symptoms. Now, this is divided on the clinical features depending what is the underlying pathogen is for community-acquired pneumonia. Is it typical bacteria or atypical microorganisms? The typical bacteria, the hallmark is Streptococcus pneumoniae. And the atypical hallmarks are Mycoplasma and Legionella, for example. We try to avoid the term typical pneumonia and atypical pneumonia, we clinicians basically. Why? Because the typical pneumonia may have atypical presentation and atypical pneumonia may have presentation. So it's better to call the typical microorganism or the pathogen or atypical pathogen rather than calling them typical pneumonia or atypical. So the typical pneumonia can be caused by typical most of the time, but sometimes it can be caused by atypical microorganisms as well. As far as the atypical pneumonia is concerned, it can be caused by typical organisms rarely, but atypical most commonly. So that is the way we go. We talk more of microorganisms rather than pneumonia. So coming back to this slide, is clinical features typical of bacteria or Legionella because they share similar. Is a hyperacute presentation. Presentation may come with septic shock, may come with absence of upper respiratory symptoms, and the initial upper respiratory illness followed by acute deterioration, which suggests in the viral infection with bacterial superinfection. The white cell count may be more than 15,000 or maybe less than 6,000 with increased band forms. Dense segmental or lobar consolidation. That's the hallmark. Typical organisms cause a dense lobar consolidation, whereas the atypical organisms generally cause patchy bilateral consolidation rather than dense lobar consolidation. Procalcitonin level will be more than 0.25 micrograms per liter. Clinical features favoring atypical bacteria such as Mycoplasma, Chlamydophilia will be the absence of the factors which I have already mentioned for typical bacterial pneumonia. Family cluster, may have families running the similar symptoms in the family, very typical for atypical microorganisms. Cough persisting for more than 5 days without acute deterioration. Absence of sputum production. Normal or minimally elevated white cell count as compared to the typical one where generally is high or below normal. But here there will be normal or minimally elevated. Procalcitonin will be less than 0.1 microgram per liter. Some features this suggests that person is having pneumonia which is likely to be non-bacterial or most likely viral. There will be absence of factors that favor bacterial pneumonia, exposure to sick contents, upper respiratory symptoms at the time of presentation, which was absent, if you recall, pulmonary infiltrates, normal or minimally elevated white cell count, and the procalcitonin level less than 0.1 microgram per liter. So coming to from clinical features, we're coming to radiological features, the differential diagnosis of CAP with the abnormal chest radiograph. What else it could be? What are the differential diagnoses? Patient may have congestive heart failure with associated viral syndrome to explain the infection symptoms. Patient may have patchy bilateral infiltrates, aspiration pneumonitis, pulmonary infarction, secondary to pulmonary embolism, for example, acute exacerbation of pulmonary fibrosis, acute exacerbation of bronchiectasis, acute eosinophilic pneumonia, hypersensitive pneumonitis, pulmonary vasculitis, cocaine-induced lung injury, which is called cracked lung. So they all can come into the differential diagnosis of CAP on the chest X-ray. So this slide is generally giving you the idea of the infectious organisms. What are the common ones? What are the less common ones? And what are the really rare ones? And sometimes we have a non-infectious components as well. So this is showing from the common causes on the left-hand side column. Infection is Streptococcus pneumoniae, Haemophilus influenza, Staph aureus influenza virus, non-infectious pulmonary edema, lung cancer, ARDS. And the less common ones among the infectious group would be Pseudomonas and other gram-negative rods. And very uncommon that thing present acutely would be the Mycobacterium tuberculosis at times, can also present infectious, non-infectious pulmonary infarction, less common, and rarely are the POP, cryptogenic organizing pneumonia, and sarcoidosis, for example, and vasculitis. Now look at this chest radiograph. What do you think? Is it a pneumonia or atelectasis? Atelectasis, in general terms, you call it collapse. So it is a collapse or pneumonia. What do you think? Think over it, then we'll go through it. Okay. Let's discuss. Let's see it. Okay. So this is the slide showing the radiological differentiating features between an atelectasis or collapse from pneumonia. In atelectasis, there would be a volume loss, whereas in pneumonia, the volume loss will not be present. Sometimes it is even paradoxically increased. Sometimes. In atelectasis, there will be an ipsilateral shift, the shift toward the disease side of the mediastinum, trachea, for example. Whereas in pneumonia, there will be no shift or contralateral shift, neither to the same side nor the other side, no shift of the mediastinum scene. Linear or wedge shift in case of atelectasis, whereas pneumonia will be consolidation with the airspace process. The wedge shape atelectasis will have the apex, the triangle of that wedge shape, the apex would be towards the hilum, whereas in pneumonia is generally not centered at hilum. Air bronchogram is not a differentiating feature because it can be present in pneumonia, and air bronchogram can also be present in atelectasis. Okay, so coming back to the same slide which I've shown you, see, this appears to be what? Wedge shape with the broad base towards the center or hilum, but the apex is away from the hilum, isn't it? It's towards the periphery. You see the shadowing. This is not atelectasis. This is likely to be pneumonia because there is no volume loss. The trachea is almost central. So these features favor pneumonia rather than atelectasis. The lateral X-ray is also showing the middle lobe, and among the pneumonia, what lobe? It's likely to be middle lobe because the right cillhead sign is present. This slide is showing again the infiltrates in the upper zones, but sparing the apex slightly, but it is still in the upper lobe. You can see on the lateral one, it's above the fissure. Legionella. This slide is showing the atypical organisms features: bilateral lung involvement, patchy infiltrates, not involving densely in one lobe. Is typical, is not typical, it's atypical, which is may have a Legionella. Now, how to assess the severity? There are several severity assessment tools available. The United States, the Americans use the PSI, Pneumonia Severity Index. And this is established because of their research done in New England Journal of Medicine back in 1997 by the Port study. And they suggested this complicated, it looks to be complicated because it requires 20 variables to calculate this thing, PSI. So one thing to assess the severity is based on the tools, which is known as PSI, Pneumonia Severity Index. But there are other tools as well, which are much simpler, which is known as CRB65. They are the British rules. and mostly used, more popular in Europe, is CRB65 score, for example. Another is CURB65, which is known as CURB65. We'll discuss both of these. The CRB65 score means C stands for confusion, R stands for respiratory rate, B stands for blood pressure, 65 is the age. All right. So 1 point for each feature is present. So if confusion is present, we give 1 point. Respiratory rate is 30 and above, we give 1 point more. If the blood pressure of systolic of less than 90 or diastolic of less than 60 or equal to 60, we give another point for blood pressure. And if age is 65 and above, we give another point to 65. So you can sum respiratory rate 2, blood pressure 3, and age is 4. So there are 4 variables. The maximum can be 4 score, and the minimum can be, if all are not present, will be 0. So from 0 to 4 would be the range, isn't it? Okay. So based on this thing, the range, we divide this score, CRB65 severity score, into 3 groups. Low severity, when the score is 0, none of these features present, the score is 0. And intermediate is moderate severity, when the score is 1 to 2. And we call it high when 3 to 4 score is present. So the low severity, based on assessing the severity, we can decide whether we need to admit this gentleman or the lady to the hospital, or we have to manage that person as an outpatient, right? And secondly, the second importance is you not only decide whether to treat as outpatient and inpatient, and if inpatient, whether to treat in ward or you requires the HDU or special care unit or ICU for that thing. It helps in deciding where to admit and at which level of care patient may require. And second, also the choice of antibiotics, which has also been influenced by the CURB65 or the CRB65 score. The CRB65 does not have any laboratory variable. As you can see, confusion can be assessed clinically, especially by doing mental score. Respiratory rate is the clinical examination. Simply count the respiratory rate. Blood pressure, you can take it in the clinic. Age, you can ask the history. So no laboratory investigation is required. The beauty of this score is no laboratory score is required to calculate the CRB65 score. So this can be used in remote areas in primary care health settings, for example. But so we have a better. So low severity is likely home for treatment. Moderate severity, you can consider hospital referral if there are social circumstances present and home support not available. You might admit them. And the high severity needs urgent hospital admission and start the antibiotic empirically. So this one is the generally we use in hospitals or the emergency care with CURB65. The only difference between the previous score and this one is the addition of urea. U. So the one laboratory investigation is required is urea. So the results are the same. You result the X-ray reviewed by clinician, no consolidation, reassess. If there is consolidation, does the patient meet the criteria for CAP? Yes. If it satisfies the definition of CAP, we go to assess the severity because based on CURB65, here the urea is more than 7 millimoles per liter, or if you are using the plus 20 and above, the cutoff. So here the severity levels are from 0 to 1. Low severity, the risk of death is less than 3%. So they can be handled as an outpatient, most likely. Okay. And moderate severity, the risk of death is around 9%, and they require hospital admission. And high severity, the risk of death is around 15 to 40%. So they require urgent hospital, preferably in ICU or special care unit. Now there is a specific term which was, as per guidelines, mentioned was severe community acquired pneumonia. So pneumonia, CAP, and the specific definition for severe community acquired pneumonia is the criteria of minor and major. We will not go into the detail, but just for the sake of completeness, I have mentioned. So before we go management, there are certain questions. We discuss the questions and answers that will help us in how do we manage a person. So we have diagnosed a person. Now, person is having respiratory tract infection. Number one, the respiratory tract appears to be lower respiratory tract infection. Among the lower respiratory infection, the infection is satisfying with the definition of CAP. And as per the CAP, according to the severity assessment, now we are dealing with how to manage. So the question number one is, in adults with CAP, should gram stain and culture of lower respiratory secretions be obtained at the time of diagnosis? The answer is, general recommendation from the current guidelines is don't recommend generally obtaining sputum gram stain and culture routinely in adults with CAP, especially for those who are managed in outpatient setting. You can do it. We can recommend the obtaining the pre-treatment gram stain and culture when the persons are classified as severe community acquired pneumonia, or they are intubated or being empirically treated for MRSA or Pseudomonas. Otherwise not. Generally. Okay. Question 2. In adults with CAP, should blood cultures be obtained at the time of diagnosis? So generally, obtaining blood cultures with CAP should not be done for outpatient setting. For inpatient setting, yes, they can be done in these specific exceptions, which are classified as severe CAP. Those who are treating for MRSA, Pseudomonas, or being previously treated for these things, or be currently been receiving antibiotics, especially during the last 90 days. Question 3. In adults with CAP, should Legionella and pneumococcal urinary antigens be tested at the time of diagnosis? Suggest not routinely doing these tests in urine for pneumococcal antigen in adults, except again for those adults with severe CAP. Question 4. In adults with CAP, should a respiratory sample be tested for influenza virus or circulating in the community? We recommend to. If there's an epidemic, we have to do it. Okay. And we're doing it. Okay. Question 5. In adults with CAP, should serum procalcitonin plus clinical judgment versus clinical judgment alone be used to withhold antibiotics? So we recommend that empiric antibiotic therapy should be initiated in adults with clinically suspected and regardless of the initial serum procalcitonin levels. Question 6. Should a clinical prediction rule for prognosis, such as CUP 65 or the pneumonia severity index, we call it PSI, plus you do the clinical judgment, or you do it just the clinical judgment and do not check for any rules, be used to determine whether inpatient versus outpatient therapy would be CAP. In addition to clinical judgment, we don't recommend alone clinical judgment. We require clinical prediction severity assessment tools in order to do that. We skip that one. So in outpatient setting, which antibiotics are recommended for empiric treatment of CAP and influenza? So person has been diagnosed with CAP, person is being, you decide according to severity, this has to be dealt as an outpatient, does not require admission. What antibiotics you would recommend? So this is the answer to this one. So no comorbidities. You look for comorbidities, hypertension, diabetes, for example, they are comorbidities, or there is a risk factor for MRSA or Pseudomonas. If not present, then the standard regime is to give them amoxicillin or doxycycline or macrolide if the local resistance of macrolide is less than 25%. But with comorbidities as an outpatient CAP, remember the patient is outpatient treatment. You combine amoxicillin, clavulanic acid, calvinate, or you use the cephalosporin and macrolide. So you use a combination, amoxicillin calvinate with macrolide, for example, or you can use a monotherapy as well, which is with the new respiratory fluoroquinolones. Okay. These are the abbreviations for this. Okay. Now, in the inpatient setting, the last slide was outpatient. So this is the inpatient setting, patient who has been hospitalized. Which antibiotic regimens are recommended for empiric treatment of CAP without risk factors for MRSA? So no risk factor for MRSA and patient is in hospitalized, admitted, and we have to give the empiric treatment. What antibiotics? Choice of antibiotics. So non-severe inpatient pneumonia, standard regime is use the beta-lactam plus macrolide, or you can use the respiratory fluoroquinolone as alone. And severe inpatient, beta-lactam plus macrolide or beta-lactam plus fluoroquinolone combination. Okay. No, these are the things for inpatient to label accessory and drug resistant, what cultures has to be done. All right, we go further. In the inpatient setting, should patients be suspected aspiration pneumonia receive additional anaerobic coverage beyond the standard empiric treatment camp? Generally, we think of aspiration pneumonia, there is a possibility of organisms having aerobic as well as non-aerobic as well. So we suggest not routinely adding anaerobic coverage for suspected aspiration pneumonia unless there is lung abscess or empyema is suspected. So for anaerobic, generally the metronidazole, which is commonly known as flagyl, or the clindamycin, they are generally considered. But in this case, generally we should not go for aspiration pneumonia to adding the anaerobic until unless we are suspecting that this pneumonia is not simple pneumonia, it is lung abscess as well, or empyema is associated complication is present. Yes, then you can add the anaerobic coverage. Should adults with CAP and risk factors of MRSA or Pseudomonas aeruginosa be treated with extended spectrum antibiotic therapy instead of standard? So we recommend abandoning use of prior categorization of healthcare. This is I have already discussed. The HCAP term को abandon किया जाता है ज़्यादातर to guide selection of extended antibiotic therapy. Now another question: the patient has been hospitalized. Should adult with CAP be treated with steroids? So should pneumonia with antimicrobial therapy as an inpatient, steroids should be added? Not routinely done in adults for non-severe. The only thing when we can add steroids in adults is with severe CAP. So if the person is having severe community acquired pneumonia, yes, you may use corticosteroids along with the antimicrobials. In adults with CAP who test positive for influenza, should the treatment regime include antiviral therapy? We recommend, if this has been positive for treatment such as oseltamivir, we prescribe for them. All right. In adults with CAP who test positive for influenza, should the treatment regime include antibacterial therapy? We recommend that standard antibacterial treatment be initially prescribed for adults with clinical and radiographic evidence of CAP who tested positive for influenza in inpatient and outpatient settings both. In outpatient and inpatient adults with CAP who are improving, what is the appropriate duration of antibiotic therapy? Now you have diagnosed a person with CAP, and now the question is how long the antimicrobial should be given. So we recommend that the duration of antibiotic therapy should be guided by a validated measure of clinical stability, resolution of vital signs such as heart rate, respiratory rate, blood pressure, oxygen saturation, temperature. The first thing is the resolution of the vital signs, which were abnormal previously. Now they all should be, excuse me. जी मैं लेक्चर ले रहा हूँ सर, ठीक है जी, मैं लेक्चर ले रहा हूँ, कल मैं कर दूंगा क्लिनिक, ठीक है, थैंक यू जी. So ability to eat and normal mentation. Antibiotic therapy should be continued until the patient achieves stability for no less than a total of 5 days. So the antibiotic therapy is no less than total of 5 days after achieving basically the clinical stability. And what is that? The normalization, the resolution of the vital sign abnormalities of heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature. And then the ability to eat and normal mentation. In adults with CAP who are improving, should follow-up chest imaging be obtained? So those persons with CAP whose symptoms have resolved within 5 to 7 days, we suggest not routinely obtaining follow-up chest imaging. The last slide probably is assessment of non-responder. You have done the right diagnosis, but what is why the patient is not responding to the treatment? The possibilities. The possibilities are: number one, wrong diagnosis. Diagnosis is not correct. The patient will not respond. You think those infiltrates were pneumonia or CAP? They were not. They were atelectasis. You misdiagnosed. Patient was having pulmonary embolism, not community-acquired pneumonia. You misdiagnosed. Person was having ARDS. You thought of it as bilateral pneumonia, but it was ARDS. You will not respond to the antimicrobial alone. Pulmonary hemorrhage was there, which was not being suspected or treated. So the wrong diagnosis will obviously not lead to the right results. Sometimes the diagnosis is right, but still the patient is not responding. Then what are the reasons? The reasons are that maybe the person is having wrong organism, inadequate therapy, or the organism is resistant. It will not respond. And at the time the diagnosis was right, the organism was also maybe right or right, but the patient has developed complication such as empyema. And this, you are not dealing with empyema, you are not draining the empyema, means pass in the pleural space in general terms. So you have to take it out, lung abscess or drug fever. So these are the few causes, few reasons when the person do not respond to the treatment. Thank you very much. जी, एडमिनिस्ट्रेटर साहब, हेलो
जी सर।
हाँ जी भैया, तो तुमसे लेने क्वेश्चंस लेने, हम बंद करते हैं, ठीक है? चैट खोलूं?
सर ये चैट में क्वेश्चंस आए हैं सर।
चैट को मैं यहाँ पर मेरे सामने नहीं आ रहा ना, तो बड़ा कर दूंगा चैट को मैं।
सर वो मोर के ऑप्शन में आएगा सर चैट।
हाँ जी, क्वेश्चन एक पूछा गया है कि सर व्हाट इज यूज्ड इन पाकिस्तान फॉर निमोनिया सिविरिटी इंडेक्स और कर्व 65 और पोर्ट स्टडी? वी generally we follow curve 65, CURB 65. CRB 65 is generally for primary care settings or at the family physician or general practitioners levels, but in hospital and emergency setting and most of the time we are using curve 65. That means only one investigation, the rest are all clinical. CURB 65 in general. Yes. In general, pneumonia severity index is also used at times, but generally we follow easy to do it.